All right, that's our cue to get started. If you need closed captions on today, at the bottom of your screen, there is the option to do closed captions. So go ahead and turn those on. Welcome to our early intervention echo. We're thrilled to have you. If you will put your name and contact information into the chat, that again just helps us get to know each other on this virtual call and where we're all from. As you noticed, we are recording today's session, so by staying on the call, you're consenting to being recorded. We do use these videos, and you are free to share the videos with colleagues or families and other people. We store those on our Canvas page, as well as our YouTube channel. If you're like me, it takes me a minute or two or 10 times, 29 times to get some information into my brain. And so going back and reviewing what is talked about is always helpful for me. Key components of an echo session is we do have a subject matter expert. Today we are thrilled to have one of our amazing hub members, Kait Bennington, who is going to be talking to us about feeding. And then we have a great case presentation by Brianna, who we will then go into small breakout rooms and discuss and come up with recommendations on that case. And just always doing the professional networking. So learning who is out doing the same work that we are doing. We love interactions, so if you have any questions or comments or thoughts, put those into chat. Kurt Phillips monitors that chat for us, and so we'll be able to make sure those questions or comments get asked and answered. We love case narratives. It's a great way to just solidify our skills or get confirmation that what we're doing is actually accurate. So if you are interested in getting or submitting a case, please reach out to us and we will get you on the calendar. Again, just some session etiquette. Please remember to be respectful of our presenter. Keep your questions brief and on topic, and introduce yourself. Sometimes on the call, it's hard to know who's talking, so saying your name and where you're from helps us identify where you are, as well as the presenter. And then again, we just encourage you to turn on your camera during the session. Sometimes as a presenter, when you're staring to a bunch of black screens, it's hard to do that. And so seeing friendly faces, like I can see Kate's and of course Brianna's, because they're the last people that talk to me on my screen. So it's always helpful to see that. When you are talking about anything, remember to protect individual privacy. If you have any questions about de-identifying or what constitutes individual privacy, you can reach out to one of our hub members. They all have an asterisk or now have an asterisk in front of their name. That just makes them easier to find in chat, so you don't have to scroll down and find them. Thank you to everybody who completes our surveys. The surveys is what we use in order to keep these sessions free of charge. So we can go back and share it with our funders and our agency to say, here's the amazing work that ECHO is doing. Please continue to support us. And that is how we then send you a certificate of attendance. Throughout today's session, Tori will be dropping in the survey link for you to use, as well as Kate's presentation PowerPoints. However, we do store all of this on our Canvas page as well. So if you want access to our Canvas page, please email earlyecho@usu.edu and we will get you set up with an invite to our Canvas page. Just another plug for those case studies. I know sometimes it's nerve-wracking or scary to do a case study. If you're interested in doing that and you just don't want to be the one to present it, reach out to me. I'll be glad to share your case and get that feedback that you can take back and apply. Also, all of the recommendations that each of the breakout groups gather are compiled and stored on our Canvas page. So if you're like, ooh, that was a great idea, I want to use it with my family, feel free to download and use those recommendations. There are so many amazing providers and experience on this call, and some of the resources that are given is just amazing. So if you've not taken a minute to go back and look at those, do that. We do have social media. If you've not followed us on social media, take a minute to do that. It's a great way to learn about our sessions, information that is shared with us, and uh, and then I'm going to stop this share and I'm going to turn the time over to Kate, and I'm going to pull up her slides so that we can get started on that.
All right, thanks, Janelle. Hopefully it
Okay,
all works this time.
there you go.
Gee whiz, technology. Um, cool. Thanks everyone for coming. I'm excited to talk a little bit about feeding today and just kind of the beginning stages and what that looks like. Yeah, so we can go to the next slide. This is just a little bit about my background. I am an occupational therapist. I have spent most of my time immersing myself, in the early intervention world, really, and with a couple of years doing some developmental assessment clinics. But during my time in EI, I have really tried to take a deep dive into the feeding world. I still have lots to learn, but here's some of the models that I have been trained in and are informing the information that I'm sharing with you today, just so you know a little bit about where my information is coming from. Next slide. Thank you. So, yeah, feeding foundations. It's a pretty broad topic, and there's a lot going on with feeding. It's a complex skill and routine. So, today I will only be able to skim the surface on the foundations of feeding. So, I've just selected a few key points to highlight. This is not comprehensive, but I hope it gives you a good starting point to think about in typical feeding. So, the first thing that we'll go over is the context in which feeding development occurs. And then we'll go over a few key developmental stages of feeding that I've kind of identified what they look like, what skills they're working on, what's the typical behaviors that we see during those stages. And then just ending with when do we need to ask for further help? When do we need a feeding therapist to intervene? And then resources that you guys can use as providers and also share with families and parents. Next. So, thinking about the context in which feeding development occurs, I really wanted to highlight this quote by Ellen Satter from the beginning of it's the foreword from the Pre-Feeding Skills book by Duncline and Arvidson. And it really illustrates the context of feeding and eating, saying that feeding is a relationship, treating a child's eating behavior and treating the interactions between parent and child around feeding is deeply based on trust. Eating is embedded in social and emotional issues and family dynamics. You may be asked for the first time to grapple with the impact of a child's social, emotional, physical milieu as part of helping him or her with eating. Um, I just wanted to start with that kind of larger framework and emphasizing that context that eating is not just sitting down and ingesting food. It's not just the nutrition. Mealtime is a relationship. There's a lot going on there that all needs to be considered. And so on the next slide, we have some of those examples of the social, emotional issues and family dynamics that Ellen Satter was referencing. Um, each of these play a role in how, where, what, or how much a child will eat. And starting with the cultural influences, right? This is pretty obvious that they'll influence what meal times look like, what types of foods are offered, the utensils that they may or may not use, and then just different beliefs about self-feeding and skills and meal times and what those should look like. Environment and routines also impact mealtime. Obviously, they're important to check in on when trying to identify barriers or strengths for a particular child. And then parents' views and beliefs about feeding and nutrition influence mealtime, including what they perceive as a successful meal. It looks different from family and parent individually. So these are all just some of the contextual considerations, just a few of them, that we have to keep in mind to understand the child's eating behavior. Today, I will primarily be focused on the physical and behavior development in relationship to feeding, but just don't want to forget the whole context when it comes to intervention, as well as the child's development in other areas, cognitive development, language development. Those things all impact what mealtime and eating goes and how it goes. So let's jump into the different developmental stages. These are just ones that I kind of identified for my organizational purposes, these three main stages of early eating. I just divided it based on like the skills that are being acquired at that time and typical behaviors that we see during these different stages. So we have the birth to 5 months. That's we're focused on homeostasis, which I'll dive into a little bit more, and postural stability. Then we get to the 6 to 12 month range, which is my ultimate favorite range. That's when we start thinking about the introduction of solids, and there's a huge burst in oral motor skills and that fine motor skill, if you will, and that development. Then the final stage, I said 1 to 3 years beyond, but especially in those first 3 years, we still see a lot of that practicing and that skill mastery going on. And then we're also dealing with them wanting to be independent human beings and what that looks like during mealtime. All right, so birth to 5 months, homeostasis, posture stability. Those are kind of the two things that we're focusing on at this time, which that's a very like simplistic view of it. There's obviously a lot's going on, but let's jump into it. So, the next slide about the first meals. So what's being offered during this infancy stage? Liquids only, formula, human milk through the bottle or the breast. The skill that's being mastered at this time is coordinating that suck, swallow, breathe pattern. With that, they are focused on moving the liquid bolus from the front of their mouth to the back of their mouth. Um, and just very linear, front, back, starting in that direction of movement in terms of how our mouth is moving. For the first 3 months, or 12, about 12 weeks, sucking is reflexive, meaning if the nipple is placed correctly, they're going to suck, and sometimes even if they don't want to. At around the end of 3 months, beginning of 4 months, sucking becomes a choice. It's more volitional, and it's very common to see regressions at this time, which often are just the babies exercising their free will. They can say no now, and so they do. It can be very concerning and stressful for parents, right? There's a lot of worry about, is my baby drinking enough? And then there can be unintentional increased pressure put on the baby at this time, which isn't always a good thing. And so this can result in parents often introducing solid foods around 4 months or a little bit earlier than we may think because um, they're nervous about the calories and getting enough. Um, but this is one of the reasons why positive bottle and nursing experiences are so important in those, particularly those first 3 months. Um, I just because sucking isn't as volitional and they don't have the control, we can see that if it becomes stressful during those early days, when they transition to the 3 or 4 month stage, they say, no way, no how. I don't want to do this anymore. This is stressful for me. And we really want to be mindful of that stress. which brings me to the homeostasis. Dr. Aaron Ross's work focuses a lot on this idea of homeostasis in the early days. Babies have a lot of new experiences and sensations that they have to learn to regulate through, including sleep and wake states, emotional states, breathing, hunger, satiation cues. Their little bodies have a lot of what I call check engine lights going off that they're learning to understand and respond to. And learning occurs best when we're well regulated. So we want to help infants during this time achieve that homeostasis or regulation before and during a feeding to help support those positive associations. Um, with that, a common question I get at this stage is how much should my baby be drinking? While there are guidelines on and kind of recommended amounts or typical amounts that we see, ultimately, healthy term babies are typically able to regulate the amount that their bodies need throughout the day. And it often varies between feeds, particularly with nursing. Um, but we do see them mostly being able to regulate themselves. The next slide, one more, we're on reflexes. Thanks. All right. I don't know if there's a delay on my end or not, but it took me a minute to see that. Thanks, Janelle. So during this stage, reflexes are huge, right? We have a lot of oral primitive reflexes that are believed to pave the motor pathway to developing many necessary oral motor skills, beginning with the rooting reflex. I'm sure we're all really familiar with this, where there's a touch to the cheek and it results in opening the mouth and turning towards the touch to help find the source of food. There's a phasic bite reflex, where there's stimulus put to the teeth or gum and it results in that rhythmic bite and release kind of pattern. It's typically integrated around 9 months, but can begin to help with chewing. The tongue thrusting or extrusion reflex has multiple names. People call it different things. Um, is when the tongue pushes out, when there's stimulus put to the tongue or something in the mouth. It's very protective and preventing little babies from getting something in their mouth that they're going to choke on that their body's not ready to yet to be able to manage. Um, this one can be particularly frustrating because it typically integrates between 5 and 6 months. And oftentimes we are starting purees or some solid foods before that stage. And so we can see that the tongue kind of gets in the way initially, and kids just reflexively are spitting it out. Sometimes parents think, oh no, my kid doesn't like this food. They don't like solids, but oftentimes it's just a reflex that's getting in the way. And they also don't have great control of their lips at that time either, so they don't have anything to kind of help hold it in, so the tongue just pushes it right out. Another big reflex at this time is for oral motor skills is the transverse tongue reflex. This is where a touch or taste stimulus is applied to the side of the tongue and the tongue moves towards it. So it's the beginning of that tongue lateralization, and that typically integrates between 6 and 8 months as well. There are also a few hand and mouth reflexes that they believe that are help start forming that hand to mouth connection. The palmomental reflex, where there's a touch to the palm and there's a wrinkling of the mentalis muscle in the chin. The Bowkins reflex, where also pressure to the palm and the baby will open their mouth and kind of move their head towards the source of food. Um, and then they see that there's this correlation between the grasp reflex and the sucking reflex, where typically when you think about the grasp reflex, right, you put your finger in their hand, they grab it, and if you give a little traction or kind of pull away a little bit, their grasp tightens. But they also see a tightening in the grasp when infants are sucking. And so there doesn't necessarily have to be that traction, but just some sucking, and the babies grasp on a little bit tighter. So that's just another reflex that they think helps begin that hand to mouth connection. And feel free if anybody has questions at any point, let me know. You can just come off mute, or Janelle or Kurt or somebody I believe is watching the chat for me. Um, all right, so let's jump into the next big focus of this stage when we think birth to 5 months in terms of feeding, postural stability, lots of development going on there. Um, Most of the time, in terms of the mouth in these early months, the our skills in our mouth are mostly linear, forward and backwards, up and down, um, and relatively more simple with the suckling and the sucking. The brain at this time is more focused on the complex skills of postural stability. And before they can move on to those more complex oral motor skills, we have to have that postural stability. So, those foundational skills, we're all pretty familiar with them. Having head and neck control, right, is important. That core stability, being able to hold them upright and maintain them upright. Um, Rolling and rotation is actually, we don't necessarily need babies rolling before we introduce solids, but we do feel like that crossing the midline is helpful in being able to cross the midline in our mouth as well, which is what we need to be able to chew effectively. Visual tracking, being able to see the food, the spoon coming, or be able to see it on your tray, and be able to develop that hand-eye coordination of bringing the food to their mouth. So reaching, grasping, releasing are important. And you'll see in a video a little bit later how when those aren't as well established, it can be kind of frustrating for little kids, along with like the eventually that neat pinch or grasp when needing to pick up smaller things. And then hands to midline is also helpful. During these birth to 5 months, nursing and bottle feeding typically encourages this. Um, However, sometimes we as parents don't realize how we might be inhibiting this when we swaddle them, or how we hold them kind of prevents them from being able to put their hands on the bottle or put their hands on the breast. So just being mindful of that. But by 6 months, kids typically have a good foundation of these postural stability skills and are more ready for those pureed and textured foods. Next slide. Uh, so, um, Birth to 5, we're also thinking about oral exploration and how important that is. It's huge for the first whole year of life, but particularly I like to focus on it before the transition to solid foods, because it offers a great foundation for what our mouth needs to do. Oral exploration starts with the bottle, breast, pacifiers, fingers. Then we move on to the world as they gain more reaching, grasping skills. They're eating whatever they can grab, right? Which is what we want to see. The hands and the mouth have the highest number of sensory receptors per square inch, compared to any other part of the body. So they're getting a lot of feedback when they are putting things in their mouth. It's how they learn. They learn about the textures, they learn about the taste, they learn how to manage these textures and tastes, um, how to be able to move them around in their mouth, how to spit them out, how to swallow them, all those things. And then it's also oral exploration is important for the gag reflex and helping integrate that and move it a little further back rather than having it more up front as it is when babies are young. It has to gradually move back so that they're not just gagging and spitting out everything, because we do want them to eat. All right. This is just a little like behavioral plug that I put in about the first 5 to 6 months, particularly at the 5 month stage. I call it the squirrel phase. Most kids become so distracted during feeding sessions around this time, and they're making huge leaps cognitively and motorically, and eating is just boring, and they have some serious FOMO. So they want to be a part of the world, which is great and a beautiful thing, and truly kind of persists throughout childhood, just ebbing and flowing based on their motivation and stuff. But Dunn, Klein, and Arvidsson, they really emphasize the importance of respecting what they call social pauses, when kids do take those breaks when they're eating. They say they're important in feeding. The parents need to encourage these by responding to their child, smiling, talking, etc. And I mean, ultimately, this is important for social development reasons as well, but it also facilitates in those positive associations during meal times as well, which is important. Um, all right, so let's move on to my favorite stage, the 6 to 12 month. A lot happens in terms of eating at this stage. We have our postural stability down. We're ready to get solids, which is exciting. And then our oral motor skills really take off and become a lot more complex in the linear forward and back. There's also, I give my coworkers a hard time about this sometimes, this common saying that food before one is just for fun. Which I get the intention of that is we're not as worried about calories at that time because they are getting formula or breast milk. Um, but I don't want to take it lightly. This is a really important time and window to be practicing those skills. So I usually say food before one is for laying foundations, but should be a fun experience. But we do want to help with those skills development and not take it too lightly and give them opportunities to practice ultimately. So before we jump into those Orimoto skills, signs of readiness, and introduction to solids, I wanted to highlight a couple of what came to me. She's the big researcher and awesome expert in feeding. She's kind of come out up with these myths of feeding, and this is a handout that you'll have a link to later that you can access all her myths and stuff. But I wanted to highlight the first three that she talks about. Um, First being eating is the body's number one priority. So that's not true. When we think about what's the number one body's priority, breathing, they'll choose to breathe before they'll choose to eat. And then actually the second one that is not as well known and is posture stability. So if a kid feels like they're falling over or doesn't feel stable enough and they are losing that balance, that's a higher priority to them, which makes sense, than eating. So eating is not the body's number one priority. Breathing, posture stability is. Next, eating is instinctive or eating is easy. Those are both not true. Um, it's a pretty complex skill, and there's at least 45 muscles involved in chewing and swallowing, and about 20 of those are just involved in like the oral phase or and require voluntary control. Like you have to have control. It's not just um, reflexive, right? And this is not even including all the muscles that are required for sitting, for bringing the food to your mouth, and overall stability. This is just in your mouth and your throat. Um, Eating is the most complex physical task that a human being engages in. It's the only task that requires every one of your organ systems and all eight of your sensory systems as well. So the body has a lot to integrate and a lot to do. So we kind of take it for granted thinking that it comes easy. It doesn't always, and kids need practice. Next slide. Signs of readiness. So these are pretty, I don't know, common knowledge, but just thought I would include it. What are the signs, signs of readiness for kids? When do we know that they are able to move forward with these complex textures? Um, Really, it comes down to that postural stability you'll see in most of these items. Being able to hold your head up, being able to sit independently for a short time, bring your hands to mouth, reach for objects. And in our mouth, we want a good foundation of that suck, swallow, breathe. And then being able to open their mouth, that cognitive visual skill as well of recognizing food is coming and opening their mouth and accepting it are all really good skills that we look for before introducing solid foods. All right, next slide. So oral motor skills. Like I said before, this window of time between 6 and 12 months is when oral motor skills can really take off. and we move beyond that linear sucking, suckling, and move on to more variation. And I don't intend for you guys to become experts in oral motor analysis, but just want to begin to help you recognize patterns and appreciate the different roles of each of the body parts in the mouth, the tongue, jaw, lip, etc. So starting with the jaw, um, mentioned this before, we start with that vertical movement. We have that munching up and down, changes going up and down. And then around 9 months is when we start seeing a little more variation. And that oral exploration is all very important and help paving all these skills with the mouth, the jaw, the tongue, the lips, the cheeks, all of that. But yeah, around 9 months, we see a little more variation in our jaw movement. We see like a combination of up and down and diagonal. And then we progress closer to around 2 to 3 years of age to that true like rotary or circular chew that we talk about. And this is when the food is completely shifted from one side of the mouth to the other side. So being able to completely cross midline with the help of the tongue, right? Um, so that, yeah, that's our ultimate goal with jaw movement is being able to get that complete rotary movement and not just vertical. With a tongue, it starts flat and in the center, we're moving forward and backwards, up and down, that very linear. And then we start to see more side to side motion. Um, we see it with the reflex, right, that I talked about before, but then once that integrates, we want it volitionally getting the tongue side to side. But being able to move your tongue to the side isn't the end of it either. We need to build the sustained, repeated side to side motion between every chew. And then eventually, we want to work on and see the tip of the tongue being able to reach to the back of our molars. That's the ultimate range of motion pattern for a tongue that we look for, and which is called tongue tip lateralization. And that skill, being able to get the tip of our tongue all the way to the back of our molars, is ultimately what helps kids be able to move beyond the mashed and meltable foods to more complex textures. They've got to be able to move the food back to their molars, which I have some videos that we'll show you in a bit too that kind of really demonstrate that so you can see what that skill looks like. Something to keep in mind is if the child isn't able to cross midline with their body, they're likely not going to be crossing midline with their tongue too. So just being mindful of that when looking at their overall development and how that's affecting eating. With our lips, movement and closure, we usually think about lip closure. And closed lips can be a sign of more advanced skills that they've learned to chew with their mouth closed, or it can be a sign that they're actually struggling with their tongue movement to get the food far back enough, that tongue tip lateralization, right, that I was just talking about. During these times of closed mouth chewing, if we're seeing that munching vertical movement rather than some diagonal movement or rotary movement of the jaw, then we're worried about the tongue movement and wonder if they're just closing their lips to keep the food from falling out of their mouth. Our tongue should be the one that primarily keeps food from falling out of our mouth. It's usually around 3 that we see efficient chewing with our lips closed, but it's still pretty hard. So even beyond at 3, I don't even expect it. It's not a skill that I really pressure kids to learn is chewing with their mouth closed. I just don't bring a lot of attention to it because sometimes it can make things harder for them, and ultimately we want the tongue doing the work. Um, we also, with lip movement, think about the progression of being able to seal our lips around a cup, a straw, a spoon, and be able to clear those things effectively. And yeah, and then our cheeks. Ultimately, our cheeks are kind of the counterpart to our tongue. They help hold food over our molars, so they don't get stuck and pocketing right in the side of our cheeks. It helps keep food on our teeth so that we can effectively chew them. And next slide. So with those different skills, the type of food texture that's being offered affects which skill that we're going to see. These are just some examples of the different textures and I have a little note to about K2Me's food list handout is really helpful. That'll also be linked at the end of the slides that you guys can reference. It gives examples of each of these different textures, which is really helpful. Um, but yeah, with each of these textures, we're going to see different skills. Our tongue and our cheeks are going to do different things. And so I'll show you a video later on about even though a child may have more advanced oral motor skills, when we're going back to the meltables textures, we kids and adults, we may revert to some of those more immature oral skills just because that's all that that food demands to be able to eat effectively. Um, so before we jump into the videos that I have, I just wanted to um, share this little bit of research that was about spoon feeding specifically. And typically, in this study, kids were offered the spoon purees around 5 months, 4.5 days, and it kind of varied a little bit, but for most kids, depending on when they started, it still took about 5.7 weeks for them to really become proficient with that anterior posterior tongue transition to be able to get that puree off of the spoon effectively and efficiently. So ultimately, I just highlight that to say it does take time for kids to figure things out. And so we do just want to create those opportunities for practice so that they can figure things out. All right, let's don't press play yet on the video. Janelle, I'll tell you when to press play. I just kind of wanted to um give a little description of what we're looking for, why I'm showing this video. This is the first introduction to solid foods for this little one. Um, and you'll see that the stability, she's still working on it. And you can really see that in her fine motor skills are not quite effective at grabbing that spoon. She wants a spoon, but grabbing it is really hard. And you can see some tensing of her other hand to try to find that stability. You also will notice that the tongue, it's it's center, forward, back, and she's just sucking it off of the little spoon that she has, and kind of pushes it out too. Like her tongue's just still trying to figure out what to do, but it's still very linear, very forward, back. Yeah, you can go ahead and press play. And there's no sound, so if you can't hear it, don't worry about it. So she does a pretty decent job getting the spoon in her mouth. But once you get it, you can just see it stays center. Her tongue kind of is pushing on it. And it just is this little sucking off of it. But this is pretty good. For her first introduction, she's doing pretty good. The next slide is actually the same experience, just a different angle. You can still see that fine motor control is really inconsistent. Trying to grab those spoons is a little bit hard. She needs help. But she has great hand to mouth, like she wants it. She's gonna try and get it. Um, but then, yeah, that sucking is still in the center of the mouth. Um, Trying to get that purees off. I also put a little note about the number of spoons. That's just a helpful hack. The more spoons you have, the easier it is. You're not fighting for utensils, and kids usually release and want to grab the new one that has the food on it, and so it makes it a little bit easier. Yeah, see, she's grabbing the tip of the spoon. Almost got it. And then ultimately just looks pretty. I mean, she's doing really well, but still a lot of balancing that she's having to work on, which makes it harder for her to grab that spoon. All right. This next video shows just her eating with a mesh feeder, if you guys are familiar with those, just has you can put a little food in the pouch. And you can see if you watch her little jaw, you can just see it's up and down munching is going on. And you can hear a little bit of sucking as well. And then ultimately, it looks kind of frustrating for her. Like she's kind of falling over. It's hard. She's still trying to put all the things together. This is still one of the first feeds that she's had. Yeah, very hunched over, but she's digging it. That little munching right there. Num, num, num. That's where we see it start. All right. So let's flash forward. Those were her first introductions. 5 months later, let's see where she's at. You'll notice a huge improvement in her spoon skills. She's able to manage that spoon a lot better. She's also bringing the spoon to the side of her mouth, and you can see she's kind of chewing on it. This video, she is eating some type of pureed, mashed, I don't know. It doesn't really require chewing, so we're not going to see that in this video, but we do see that that skill is coming. She's getting that figured out because she's chewing on the spoon and bringing things to the side of her mouth a little bit better. The spoon goes in and oop, right to the side, and you can see that chewing on it. And I believe that was oatmeal, so there is a little bit of texture to it, versus like just a puree cup. And I just saw somebody mention the honey bear cup. Yeah. Um, so there's a little bit of texture, so I anticipate that's why she's munching on it too, which is good. All right, next video. Just want to make sure. Okay. Um, so in this video, we finally see a texture change. It's like a pasta, soft mashing. Does require you to be able to mash it between your gums, though. Can't just, well, I mean, sometimes kids surprise you and they will just swallow things whole. But we do see more of that chewing and that munching. Um, Also, her, fine motor has continued to improve, which helps with the mealtime. But notice her chin. I want you guys to watch her little chin and just the direction. It's not just up and down, but you see little shoots of like going sideways. I'm trying to show you, which is pretty silly, but you'll see that variation in movement when she is chewing. Um, and then you'll see that the lips are a little bit activated and closed. So I wonder for her about like, is she getting the food, like is her tongue doing its job, getting the food far back enough? It works. She's okay because it's a soft texture food. But yeah, I do wonder about her tongue right there in this video actually. But yeah, go ahead. I think I'm seeing some questions about the age in her video in this video. So it was about 5 months. She was around one, maybe a little bit before 12 months, maybe a little after 12 months, but about 12 months. And I also want to point out that with the fine motor, a lot of people, some parents will be like, she's not using a neat pincer grasp at this time. I always just like to be real and that if you're trying to get more food to your mouth and it's not something we want to be able to have the skill to be able to pick up those small things when it's necessary, but when food is in a clump like that, we're going to be using multiple fingers too to pick it up and put it in our mouth. So just a little reminder there. Um, all right, so with this video, try not to be distracted by the battle that's going on with the sippy cup. It became a distraction, and so sorry about that. But I like this video. You see, she's more stable, she's older. And you can really see that tongue going to the side. There's one moment where she's struggling with a little bit of chicken, and you can see she has to move her tongue multiple times to be able to get position that food to the side of her mouth, which is just a great skill to see. And her lips are open a little bit more now, which communicates that I think her tongue's working a little bit better. All right, go ahead. Yeah, that darn sippy cup. And right there, you could see the tongue had to work a few times to get it to the side. Right there. Watch that tongue. Yeah. Going from one side to the other side. And I guess I should point out typical behavior. The reason why there was a battle, she wanted to throw that cup on the ground. We did not. And then the bowl wanted to be thrown on the ground. But that's just, yeah, that's kids, right? Throwing's gonna happen. All right. I don't know. Did it restart? I can't tell. Okay. This next video is what I was referencing earlier, where you'll see. So I believe we're at like 18 months now. So she has the skills to be able to chew the tongue tip lateralization, but we're eating a cracker. And so we see she reverts to that munching and mashing, and you see her lips are closed tight, and the food just kind of stuck because that works, and that's a little bit easier for her. So in this moment, we see that. And also, yes, I'm aware of the safety concerns of where the seat is placed on the counter. Adults were right there helping her. Just, yeah, don't panic when you see the up seat on the counter. Yeah, those lips, they're closed. You do see her chin moving around a little bit more, but the food is kind of just stuck in the front right there because that works. And she's begging for more. So, that's one example. I wanted to show you another little kid, to show you that not every first intro is that eager. In fact, I'd say most kids are not as eager to get different food, to try solid foods. This is more of a typical hesitant reaction and you can go ahead and start playing it, Janelle, where they're just like, what do you want me to do with this? And are you sure that you want this in my, do I really want this in my mouth? You can see that there's a rolled up towel too. We're still working on that postural stability. Um, and then, yeah, it's just, I don't know about this, which is really common. And I sometimes I feel like I hear parents kind of panic during this and think, oh no, they don't like it. But that gag and that grimace you'll see in the next video too. It's all that can be typical. That can be typical for sure. So yeah, he's not bringing it to his mouth. He's just like, I just need to play with this right now and figure it out with my hands. I'm not ready for my mouth. But in the next video, you'll see that they get there. He gets there. Um, you can go ahead and play it, and you'll see. a lot of that gagging response, like the grimace and like, I don't know. He leads it. He's the one bringing it to his mouth, which is something we always try to emphasize, um, that they are the initiators of it. But then as soon as he gets in his mouth, he's like, I don't know about this. But kudos to keep trying. That's the win I feel like there is. And kept trying to bring it to his mouth, even though he was way unsure. Mhm. All right, and this next video is just a short one that really shows how fine motor gets in the way and makes it really hard. You see, he's still in that raking grasp, and it's all like mostly ulnar pinky side that food is getting in there, which just makes it too hard to get it out. You can go ahead and play it. And then the release too, figuring out how to like get away from it and how to let go. You kind of see him shake his hand to try to let go of it. So yeah, these are early 5, 6, 7 months kind of stage of what we see with feeding and how frustrating that can be, right? So 3 months later is the next video, and we start to see more skills. We start to see the tongue going side to side, and he actually does a pretty great job of keeping his mouth open so you can see that tongue keep, doing the work. You also see the jaw going not just up and down, but side to side. There's a little more diagonal movement to it. If you were to take a ruler, right, and put it at the center of their face, the chin would go off to the side of each of those rulers. All right, and then one last one. 6 months later, how he's doing. Yeah, go ahead and play it. Um, core stability, he's good. He's sitting, balancing, able to reach and come back. The tongue movement is pretty impressive too. You'll see lots of times. That's what I want to focus on in this video is just watching his little mouth and how he bites things, brings it to the side. You can see that chin go in both directions. And you see his little cheek activated too, right? You can see a little tightening when the food is in the side of his cheek, just showing that his cheek is kind of keeping it over his molars as well. All right. So let's jump into the last stage of development that I've identified just after a year to 3 plus. At this time, practice, practice, practice is what we think about, and then just kind of mastering those skills and refining those skills of that tongue tip lateralization, the chewing, the rotary movement, and being able to cross midline, move the food both sides. And then independence. We see kids, they want to be independent. So, yeah, next slide. The skills that we see coming in, that tongue tip lateralization, like I talked about, it's really important for when we think about raw veggies, fruits with skins, and meats. To be able to efficiently chew those, we need that skill. And then we need to be able to cross our midline with our tongue in a smooth, coordinated fashion, which that truly is mostly comes out, that true rotary chew is between 2 to 3 years. Then we see them become more proficient with spoons and forks between this 2 to 3 years stage. I'd say 1 to 3, depending on what what it looks like in each kid's variation, and also opportunity. Like we yeah, we forget about that environment, that context I was talking about before. Like, are they given the opportunity? What kind of utensils are the family using, and such. And then cup drinking also we see it just gradually improve during this time as well. Um, Signs of oral modal difficulties. So these are some of the things for you guys to look out for. Um, are if their hands are in their mouth, they're using their fingers rather than their tongue to move food around. That pocketing can be a sign of cheek activation or tongue not being able to get that food out from their cheek. Also, with that sensory, right? When we think about pocketing, I know that's a common train of thought that we have is what's their sensory regulation like and their awareness. But it's probably, it can be a combination of both, right? If we don't have good sensory input, so they're not aware of where it is in their mouth, then they're not able to have that great motor output to be able to get the tongue to find it and put it back to where it needs to be. Food falling to the midline of the tongue. So if we don't see food getting to the side, but it's staying in the center, they'll see gagging, lots of gagging at this time. If that food is just staying center like that too. And then along with gagging, not being able to spit food out, that's an important life skill that we do want kids to figure out is how to spit things out when they're not able to manage it. And then during this stage, I get lots of questions about like, how much should my kid be eating? This is kind of the general frame of reference that most dietitian nutritionists reference is 1 tablespoon per year of life per food, which is kind of complex, but those examples I gave, like if you're 1 year old, you think of 1 tablespoon, and typically 2 to 3 foods are offered at a mealtime. So you think about 2 to 3 tablespoons is an appropriate serving size. Kids eat more, and if they want to eat more, I'll let them eat more. But that's kind of the minimum that we think of, the minimum goal that we strive for. All right, and then um, I'm gonna skip over this one kind of quickly. Just yeah, the myths. We don't just sit and eat. Like it's more complex than that, and we need to play with our food is the gist of that slide. I want to make sure we have a little minute to talk about picky eating because if we're thinking about typical development, picky eating is part of typical development. 25 to 50% of toddlers are reported to struggle with picky eating, so that's a lot, like, good portion of the population. Um, but only and 1/3 to 1/2 of those children with picky eating will outgrow it. So there is a large portion, the 1/2 to 1/3 of those kids that aren't outgrowing it. That's what we want to focus on as interventionists. Interventionists is being mindful of those who are not outgrowing it. And so I linked a article, or a handout by Kay Toomey that talks about problem feeders versus picky eaters. I really like this handout that kind of talks about like what's the difference, like what's typical picky eating versus what's not. So you guys will be able to have that and reference that. But in terms of typical picky eating and how we respond to that, really it's all about that mealtime atmosphere and making sure that we're making it a positive, social, fun, playful experience. And then presentation matters at this age. I just kind of imagine kids at this stage as little food critics and judging, how does this look? Am I okay with this? And being playful and inventive and how we offer food and changing up how we offer food really is helpful with these typical picky eating behaviors that we see. Um, and I won't show this video. It's just the little guy eating ice cream, but just the point that I wanted to emphasize is that even with things like ice cream, this little guy was like, no way, no how, I don't want this. But we had to change up the spoons that we offered it. First it was on the plastic spoon that I, you know, I was eating from. And then it was from Sister Spoon. And then, no, that didn't work. Okay, what about Dad Spoon? Okay, we'll get you your own little spoon. No way, no how. I want control of the spoon. And you don't just set it preloaded on my tray, but I want to be the one that scoops it into the cup and, keep the cup in my space. Don't take it too far away. So just all those little nuances of meal times about presentation, the position, having that sense of control, and then embracing the mess can really help with those kind of typical picky eating behaviors. Um, when to seek help. I've also attached a handout about some of the red flags of picky eating and eating difficulties that you'll be able to reference. But a lot of the things are if we're concerned about weight gain or growth, if we see lots of choking or gagging, vomiting, um, if parents are reporting that their child is being picky, at two or more well child checks is kind of one of the standards that they have. Not being able to eat purees, like transition the purees from the front of their mouth, like take it off the spoon, right? By 10 months of age, or not doing any table foods by 12 months of age. Those are all examples of things that we would want to seek more help and see what's going on. I also just put in a little plug that if we're seeing gross motor delays, to check in about feeding too, because oftentimes when there's gross motor delays, we also see oral motor skill delays. And then ultimately, if the parent feels that there's a breakdown in mealtime, then I think intervention is warranted just because the environment and the atmosphere around mealtime is so influential. And this is a lifelong skill that we need. We want to set early, like good routines early on, to be able to help set that foundation up of meal times and being open and willing and confident to be able to try different things and eat different things. These are some of the resources that I've left links for you guys. I love the Solid Starts First Foods database. That can be a really helpful tool for parents just to know what kinds of foods can I offer my kids at what stages, and how can I prepare them to decrease choking risk. It also talks about allergy information. I will say if you guys aren't familiar with this, this is a very baby-led weaning focused platform. And I just always say I'm not saying baby-led weaning is the way to go. Every child's different, and for some it's not appropriate. But this food list database that they have is helpful just to understand how to offer foods. Then Ellen Satter's work on the division of responsibility, super helpful to help with that mealtime atmosphere of like what's the expectation of parents, what's the expectation of children, and eating. Kay Toomey, she's the creator of the SOS approach. So I put a link to her website for those handouts that I talked about, the red flags handouts, the picky eating versus problem feeders, and then the myths about meal times and eating. Those are great resources to share. I love Chicago Feeding Group, and specifically talking about responsive feeding and how we can be more responsive and sensitive to those cues. And yeah, they have lots of great trainings that are free for parents, which are cool, and pretty cost effective for providers. Feeding Matters is a great advocacy program about kids that, have feeding difficulties and finding support and help there. And then I often reference this, the healthychildren.org, about and the ages and stages to know like what's typical for kids and eating. So that's just can be another resource that you guys can have. And yeah, there's my sources.
Okay, there was a question in the chat.
Okay.
Jennifer said her friend had a baby Saturday. It's in the NICU, won't suck or eat. Any tips or resources for mom?
Mm. That's a loaded question. Where to begin? Um, I that like that idea of regulation and just trying our best to keep positive oral experiences is really huge in that. You can check out Feeding Fundamentals is Aaron Ross's work on NICU babies, and being able to help in that environment. And so you could check out her website and see some of the things that she talks about. But um, just trying your best to be calm, help them get in a regulated state, if they need to be swaddled, if they need to, and keep positive connections with oral experiences. And I know, and this is not advice for this particular child, obviously, because I don't know. Um, I'm just saying in general, I have seen that for some kids that are really struggling with lots of reflux and gagging and vomiting, sometimes taking a break from the stimulus just to not keep building those negative experiences can be helpful. So, um, yeah, just checking in with the therapist there and just saying and asking them too, how can we keep these positive experiences for our baby? Oh, that's hard. I hope the family's doing okay and wishing the best for them.
Thank you so much, Kate. I am going to quickly turn the time over to Brianna to share her case and that we can get to it.
Yes, sorry.
Well,
Okay, hold on. Sorry. Thank you, Kate. That was awesome. Okay, let me go to share.
and while she's working on her share screen, if anybody has any questions that you would like us to direct to Kate, you can email Early Echo and we will make sure that Kate gets those and we follow up with you just because we don't have time to ask all these questions. Hey, Brianna, take it away.
All right, can you see it? Like,
Perfect.
okay, great. All right, so I'm Bree. I'm a speech language pathologist at DDI Vantage. I work with Kate. And the kiddo that I'm going to present today is a kiddo with cerebral palsy. And it is perfect because this month is Cerebral Palsy Awareness Month. So it just worked out great. Um, so start with a little bit of background. Um, this, I have it this way so I could see my notes, and my notes are missing. So hold on. There we go. All right. So this little kiddo has been receiving services since he was about 7.5 months old. Prenatal history. So there's a history of poly drug use. We have limited details, limited prenatal care as well. Birth history. So this kiddo was born at 22 weeks and 4 days. Presented with a prolapsed cord, which mom then got an emergency C-section, which resulted in an anoxic brain injury. He was in the NICU for 202 days. His At the time of birth, his diagnosis or problem list was fetal alcohol exposure, a bilateral IVH grade 3, I believe. Microcephaly, he had chronic lung disease, a little hole in his heart, which spontaneously closed while he was in the NICU. And then he had an MBS, swallow study while he was in the NICU that showed silent aspiration on all thicknesses. So then his current diagnoses now are he is a hemiplegic cerebral palsy kiddo, right side. He has bronchopulmonary dysplasia. So BPD, he uses a vest and has some breathing treatments that he does every day. Microcephaly, dysphagia, so swallowing. He's G-tube fed, fetal alcohol exposure, and then he has enamel hypoplasia and all these other words that you can read because I tried to say them a million times and couldn't. But basically, his teeth are brown, they have no enamel, and likely has a lot of sensitivity. So, all right. continued. So he was in foster care since I think December when we started seeing him. And that family has two adopted children from the same biological mother of the child that I'm talking about. Um, so I already talked about the NICU. Visits have now moved to the biological family's home. They have custody, and so our visits have been with them since September. He currently sees our program for speech, feeding, occupational therapy, and physical therapy. We did just do a vision referral, and we currently no concerns. He also gets outpatient feeding once a month. He's followed by pulmonology and cardiology, and currently there are no current concerns. He's pretty stable, and he uses oxygen at night. And then he's also, I didn't put this in here, but he's also followed by ENT. I think they have an appointment in a couple weeks to look at his adenoids and decide whether or not they need to take them out. All right, so there are a lot of concerns. The big ones are feeding, gross motor, fine motor concerns, sensory differences, cognitive delay, and speech and language delay. Things that we are wanting to encourage from him are intentional vocal imitation. Right now, he has limited consonant and vowel inventory, and I would say also very limited intention of vocalization. So sometimes it seems like he's trying to vocalize, but nothing comes out. Use of gestures and nonverbal communication. Sometimes he'll sign more. He's not yet pointing to requests, but can point, like to point to things that he's just talking or, playing with. He claps, he waves, and he does his arms up for up. We're wanting independent walking, which he just started. It's not yet his primary mode of movement, but it has started, which is exciting. Drinking thickened liquids from a straw cup. He will do it. He loves it, but I would say it's about 30% independent. Primary nutrition and caloric intake is through the G tube. This has progressed a lot in the last month. Just to give a little bit of background, because this is where one of my big questions is coming at the end, is that right now he will eat about like 5 to 10 pieces of dry cereal. Mom believes that that's like the amount that he actually swallows. He will eat and swallow yogurt. He will chew, but mostly uses the front of his mouth right behind his front teeth, very minimal lateralization. So lots of mashing. Tongue thrusts a lot of food out. Chews on beef jerky, likes cooked carrots, loves peanut butter and jelly sandwiches. He used to have a very sensitive gag that the second he would gag, even if he just saw food, he would gag, he would vomit. So it has gotten a lot better. I think the last time that happened was about 3 months ago. And then for sake of time, I'm going to skip through. You can read the rest of those. The textures, I will say, this has also gotten a lot better. He's tolerating textures on his hands a lot more without vomiting, with the exception of oatmeal. It has been a very challenging one. So some of the goals that I wanted to focus on today were for him to enjoy mealtime and work towards weaning off the G tube. So wanting him to swallow some more food. And then increasing his ability to interact with a variety of textures so he could also tolerate them in his mouth and enjoy them. And then imitating gestures, signs, vocalizations. Barriers. So medical diagnosis of cerebral palsy. He has global high tone. Possible effects of this that I feel like for people who don't know I think are important to know are this could potentially affect coordination of movements. Grading combination muscle contractions can be really challenging, which would result in like jerky or uncoordinated looking movements, proprioception of the tongue, cheeks, and other internal parts of the mouth, which I'm highly suspecting with this little one. And then that would also affect coordination of movement and then being able to feel different textures and temperatures. And then parents are pretty overwhelmed. They've got financial stressors. One parent is working. One parent is worried, and the other one feels like it's going to come. Like our other kids started talking at 6, like we're fine. And then the TV is on for a large portion of the day, which we have talked a lot about, but I'm being very strategic. Additional information, they weren't doing any book reading, so we've focused a lot on that. It's gotten a lot better. And then I kind of mentioned this earlier, but inconsistently being able to turn his voice on has been something that has recently really kind of reared its head. And then I don't know why I randomly put in here that they've been doing hard munchables with dip, but I thought maybe that was important. And so then these are the questions that I had for everybody.
So, Bree, I'm going to just throw a loop in here because I know there's some questions, and I know we're going to have a lot of questions for you. And I want to make sure that we allow sufficient enough time for our breakout groups to do this. And we might not have time to do that today. So I'm wondering if we can all just ask like questions to you and then do the small breakout groups where we discuss some of these community questions next month, just to make sure that we are dedicating enough time to your questions. I'd hate to only give you one or two recommendations.
No
How would you
problem.
feel about that?
That's totally fine.
Okay.
Would I stop sharing my screen?
Yeah, go ahead and stop sharing your screen. There's two questions in the chat. So if everybody if there are questions that people have that they want to get more information, and then next month we'll just do a summary and then ask and answer your breakout questions. Does that seem reasonable to everybody on the call? Kate, I see your head nodding. Okay, I got a thumbs up. Okay, so there is a question from Kate. It says, is a dentist involved in these issues? Curious of the plan of care if there's any from that perspective.
Yeah, so we got a dentist involved. Gosh, maybe it's been about 8 months now, to kind of figure out what was going on when his teeth started to come in, and we noticed they were brown. And so he is being followed. I think the plan of care right now is they're waiting for teeth to come in, and then they're gonna go from there. So I think he has a follow-up dentist appointment soon, but I'm not quite sure when.
So the other question is how is he stooling what is fed in his G tube?
Oh, Pat, I knew you were going to ask me that. I don't remember what he is getting through his G tube. The care has been pretty there's like it's not very fluid, since I actually feel really bad for the family. So they were on infant formula up until like 3 months ago when I called and I was like, someone needs to change this. He needs to have an appointment. So they just switched him over, but I don't remember what he's on. He's tolerating it really well. Stooling is typical for his age.
Right. And then the next question is, what is the child's current seating position or setup for feedings?
Yep, he has a high chair. He's very well supported in that high chair. And he is, depending on the meal of the day, he's either sitting in that and mom is sitting in front of him with a chair, or they'll pull it up to the table.
Okay. And then another question of that, is he mimicking actions or play at all?
Yeah, it's a good question. Not consistently, but yes. So some things that he's recently started doing is our OT was saying at his last appointment, he was doing the, like some things on your head and you do achoo. And so he is imitating things like that, but keeping his attention is harder. And so you might get a couple back and forth, uh, but sometimes you'll get none. And he will imitate kind of like, if you put things on a ramp, he will sometimes imitate, but again, I would say it's like 30% or so consistent.
Other questions that people would want to know about this particular kiddo?
Yeah, so is hearing or vision an issue? Vision, we were wondering about vision, especially when he seemed to have the skills to walk but wasn't wanting to. Um, and PIP vision came out and there are currently no concerns. He's using his vision great. Um, no plan for follow-up there. There was concern about hearing when he was born. They were supposed to have a follow-up, which fell through. But it sounds like at his last audiology appointment, everything is typical for his age and within normal limits.
And then what sort of sensory play is already happening?
Yeah, OT, we just recently had OT switch over to working more on sensory as opposed to fine motor. And they are working on kind of different textures with play, smells, um, a lot of kind of like hands-on feeding experiences that are child-led. But no like sensory diet or anything like that that has been put in place.
And does he put anything in his mouth, toys, or hands?
Yes, he doesn't really mouth toys all that much anymore, but he used to mouth toys quite a bit. Um, and he puts food in his mouth. I think I don't know if that's part of your question, but yeah. I would say he's pretty with food. It has taken a very long time to get him to be willing to put food even behind his two front teeth. So the fact that he is actually doing that now and swallowing is a really big deal.
Okay, so tell me more about your comment of turning voice on.
Yeah, so um, I'm thinking about like diaphragm and I'm also thinking about coordination, but basically, sometimes what it looks like is he's like we're singing songs and his mouth opens and it looks like he's like you would think that maybe he's going to vocalize, but there's nothing happens at all. Maybe you'll hear like a kind of a squeak. Um, he can do it and he definitely does it more when he's moving, um, which is again part of what's making me think about just his diaphragm. Um, but yeah, I would say like he can be very vocal, but it does seem like there are moments where he is not able to activate his voice. Does that make sense, Kate?
Okay, so again, to summarize, we will go over this case again really quickly. Okay, and put Bree's questions back up before we close out the meeting. So next month we will go over this case really quickly and then go into breakout rooms so we can discuss these questions. So be thinking about ideas and recommendations for Bree for next month. There is the use of diaphragm competing with postural stability and voice.
Sorry, will you repeat that? I can't see the question
It
anymore.
says, is the use of diaphragm competing with postural stability and voice?
I think it's a really good question. I think it's very possible. My hunch is that there's multiple reasons why this is a challenge. Just also thinking about cerebral palsy in general.
Okay. Okay, so there are her questions again. Next month, we'll be talking about typical play and going over this case. And we will just let everybody go unless there are other questions. Oh, there's another comment. It says that a thought, it seems that stabilizing the family situation and meal times is the starting point, just because there is so much going on. Likely a lot is needed from all angles of feeding, but we have to start where they are, and it doesn't seem that feeding is a positive time yet.
Just to say something really quickly, I totally agree. I will say mealtime is actually very positive. Mom enjoys it. He loves it. Um, it's more that where it's just a very slow progression.
Good clarification there.
But
Okay.
thank you.
Okay, Bree, I appreciate that you are letting us adjust to just make sure that we get the right recommendations for you. Um, thank you to everybody for joining us today. Thank you, Kate, for all the information you gave to us. So our next session, just as a reminder, is April 1st. And thank you all.